I started recording. Can you see the slide on the screen now? Figure 19.2.
Yes, hocam.
All right. So let's see a few figures from Netter, few more figures first, and then we will continue our remaining lecture. Okay? So here you see the renal response to volume contraction when blood volume goes down. I mean, when blood volume goes down, what will happen in our body? Okay? From the heart, atrial natriuretic peptide release will go down. Let me explain how it works. Okay, I think it is book. Oops, sorry, it's not the PowerPoint. Sorry, I'm not going. Just a second. Oops. Physiology slideshow. Okay. Okay. Just a second. Pointer. All right. Now, volume contraction. When there is excess water, okay, extracellular fluid volume is high, blood volume is high. Okay. Blood volume is a part of extracellular fluid. When sodium concentration is high in our body, when the sodium amount is high in our body, it means the extracellular fluid volume will be high. It means blood volume will be high. And then in the heart, atria, right and left atria, will be stretched by excess volume of blood, excess fluid. And then it will cause release of atrial natriuretic peptide. So that it means natriuresis, it means sodium excretion and water excretion, so that volume will go down. Okay? So actually atrial natriuretic peptide is a cardiac hormone secreted in the excess volume, excess blood volume. Okay, when volume is down, there is no stretch to the atria, so atrial natriuretic peptide release will be decreased. Okay. How about antidiuretic hormone secretion from the brain, from hypothalamus, and then from posterior hypophysis? It will be increased. Okay, when volume is decreased, concentration of sodium in the extracellular fluid will go up, and then volume amount will go down, and the antidiuretic hormone release will be increased. Antidiuretic hormone, what it will make, as you see, it will increase water permeability in the collecting ducts. So sodium and water will be absorbed quite much, and then sodium and water excretion will go down. What else we see in this picture? Sodium resorption in proximal tubule will go up. Okay, glomerular filtration rate will go down. Why? It is because of decreased blood volume will stimulate sympathetic nervous system activity. When sympathetic nervous system activity increases, what happens? Renal artery will be constricted. Afferent arteriole will be constricted, will be narrowed. Less blood will come to the glomerulus, less filtration will occur. Okay? And then sodium reabsorption will be increased, and by increased antidiuretic hormone, water reabsorption will be increased. What else we see? I have mentioned to you about renin-angiotensin system. Okay, renin-angiotensin system will be activated because by glomerular filtration in the distal tubules here, ultrafiltrate amount will be decreased, sodium amount will be decreased. So renin-angiotensin system will be activated, although not shown in this figure. Juxtaglomerular apparatus is not shown here, but you know what it is. And then renin secretion will be increased, and then renin will convert angiotensinogen to angiotensin 1. Angiotensinogen is synthesized in the liver, and then angiotensin 1 will go to the blood circulation, will pass through the lungs. In the lung endothelium, there is angiotensin converting enzyme, and then it will convert angiotensin 1 to angiotensin 2, and then angiotensin 2 will cause many effects, as you see. Okay, there will be vasoconstriction, it will increase antidiuretic hormone secretion, and then the person will feel thirsty and will drink water. Okay, and angiotensin 2 will also stimulate surrenal cortex to secrete aldosterone, and aldosterone will increase sodium reabsorption in the tubules, okay, and potassium secretion. Sodium absorption will cause osmosis of water, so water reabsorption will also be increased. So in water depletion, as you see, antidiuretic hormone secretion will be increased, then angiotensin system will be activated so that concentrated urine will be formed. How about excess water situation? If there is excess water in the body, hyperosmolarity or excess water in the extracellular fluid, this time atria will be stretched by a higher volume of blood, and then from the heart, atrial natriuretic peptide will be secreted, and then anti-natriuretic peptide will prevent sodium reabsorption, so more sodium will be excreted in the urine, and water will not be absorbed by collecting ducts, because there is now decreased antidiuretic hormone. If there is no antidiuretic hormone or decreased antidiuretic hormone, will decrease water permeability in the collecting ducts, okay? So diluted urine will be formed in this case. Sympathetic activity will go down, and renal artery will be relaxed, enlarged, more blood will come to the glomerulus, and then quite much glomerular filtration, and then sodium reabsorption will go down, and then angiotensin system will not be activated because there is excess sodium here, there is excess volume here, so renin amount will go down, angiotensin 1 will go down, angiotensin 2 level will go down, and it will not stimulate adrenal gland to secrete aldosterone. So aldosterone is low. When aldosterone is low, sodium reabsorption will go down, so sodium will be excreted in the urine. Okay, and there is another picture slide. After that, we will go to the text. I think after seeing these pictures, you will understand these situations much better. So there are diseases where kidneys lose their ability to concentrate the urine. One of them is central diabetes insipidus, okay? Antidiuretic hormone is synthesized mostly in supraoptic nucleus in the hypothalamus. As you see here, it comes to the posterior hypophysis, and from the posterior hypophysis it is released into the blood circulation. Okay, if there is somehow failure of chemoreceptors to detect blood osmolarity, or if there is a tumor, craniopharyngioma, metastatic carcinoma in this area of the brain or in any part of these areas, inflammation, meningitis, tuberculosis, syphilis, granuloma, xanthoma, sarcoidosis, Hodgkin's disease, or trauma, skull fracture, hemorrhage, concussion, operative or surgical complication, vascular lesions, sclerosis, thrombosis of the bloods, or unknown regions. In these cases, okay, antidiuretic hormone secretion will be decreased. Sometimes there will be a problem in the kidney tubule cells, collecting duct cells. Receptors to antidiuretic hormone are not functional, are not binding to antidiuretic hormone. So this is called nephrogenic diabetes insipidus. If there is a problem in the synthesis and secretion of antidiuretic hormone from the posterior hypophysis, it is central diabetes insipidus, but sometimes there is a problem in the collecting duct cells. Although there is enough secretion of antidiuretic hormone, these cells may not respond to antidiuretic hormone to increase water permeability in the collecting ducts. So this is peripheral diabetes insipidus, or nephrogenic. Mostly it is called nephrogenic diabetes insipidus. Okay, now I will go to now another presentation to our lecture. Now, do you see the disorders of urinary concentrating ability slide? Can anybody tell me, do you see the disorders of urinary concentrating ability slide on the screen?
Yes, hocam.
Okay, now we are continuing to our lecture, regular presentation, I mean. Our kidneys can lose their ability to concentrate urine sometimes. Impaired ability of the kidneys to concentrate urine can occur with one or more of the following abnormalities. One of them is decreased secretion of antidiuretic hormone from the brain, from the posterior hypophysis. It is called central diabetes insipidus. This results in an inability to produce or release antidiuretic hormone from the posterior pituitary, resulting from head injuries, infections, or congenital abnormalities. And the other one is inability of the kidneys to respond to antidiuretic hormone, a condition called nephrogenic diabetes insipidus. This abnormality can be caused by failure of the countercurrent mechanism to form a hyperosmotic renal medullary interstitium, or by failure of the distal and collecting tubules and collecting ducts to respond to antidiuretic hormone. Many renal diseases can impair the concentrating mechanisms, especially those that damage the renal medulla. In addition, impaired functioning of the loop of Henle, as occurs with diuretics that inhibit electrolyte reabsorption in that segment, can compromise urine concentrating ability. Diuretics are used in the treatment of hypertension, in the treatment of cardiac failure, okay, heart insufficiency. Marked increases in renal medullary blood flow can wash out some of the solutes in the renal medulla and reduce the maximal concentrating ability, especially if you use aspirin, okay? Aspirin inhibits prostaglandin synthesis and then causes vasodilation in the renal medullary capillaries in the vasa recta, for example, then wash out the solutes from the renal medulla, and then in this way, our kidneys can lose their ability to concentrate the urine. No matter how much antidiuretic hormone is present, maximal urine concentration is limited by the degree of hyperosmolarity of the medullary interstitium. Okay. In addition, certain drugs, such as lithium, used to treat manic depressive uh, manic depressive disorders and tetracyclines, antibiotics used to treat infections, can impair the ability of the distal nephron segments to respond to antidiuretic hormone. By the way, let me check if we are recording this session. Okay, we are recording. All right. Now, control of extracellular fluid osmolarity and sodium concentration. The regulation of extracellular fluid osmolarity and sodium concentration are closely linked because sodium is the most abundant cation in the extracellular compartment. Plasma sodium concentration is normally regulated within a close limits between 140 to 145 milliequivalent per liter. Osmolarity averages about 300 milliosmol per liter, and seldomly it changes more than 2 to 3%. Although multiple mechanisms control the amount of sodium and water excreted by the kidneys, two primary systems are particularly involved in regulating the concentration of sodium and osmolarity of extracellular fluid. First one is the osmoreceptor antidiuretic hormone feedback system, and the second one is thirst mechanism. When your blood is hyperosmolar, extracellular fluid is osmolar, the person feels thirsty, okay? Now the first, osmoreceptor and antidiuretic hormone feedback system. When osmolarity or plasma sodium concentration increases above normal values, the osmoreceptor antidiuretic hormone feedback system operates. Increased extracellular fluid osmolarity stimulates osmoreceptors in the anterior hypothalamus near to supraoptic nuclei to send signals that are relayed to the posterior pituitary gland. Action potentials conducted to the posterior pituitary stimulate release of antidiuretic hormone, which is stored in the secretory granules in the nerve endings in posterior pituitary gland. Antidiuretic hormone, which is transported in blood to the kidneys, increases water permeability of the late distal tubules, cortical collecting ducts, and medullary collecting ducts. Increased water permeability in the distal nephron segments causes increased water reabsorption and excretion of small volume of concentrated urine. This causes dilution of solutes in the extracellular fluid, thereby correcting the initial excessively concentrated extracellular fluid. Hyperosmolar blood now will be diluted, okay? So in this flow chart, you see these events. First, water amount goes down, okay? Then will cause increased sodium concentration in the extracellular fluid, meaning extracellular osmolarity increased. And then osmoreceptors in hypothalamus will sense these increased osmolarity in the extracellular fluid of the blood or extracellular fluid, because you know blood plasma is a part of the extracellular fluid. And antidiuretic hormone secretion will be stimulated from the posterior pituitary by sending signals, action potentials to the posterior pituitary, and then plasma antidiuretic hormone level will go up, and then antidiuretic hormone will increase water permeability, will open water channels in the distal tubules in the collecting ducts, and water will be reabsorbed, and then blood osmolarity, extracellular fluid osmolarity will be decreased because the solutes will be diluted in this way. And in the urine, water amount in the urine will go down, and then concentrated urine will be formed. So the opposite events will occur when extracellular fluid becomes diluted, okay, hypoosmotic. Now, antidiuretic hormone is synthesized in the supraoptic and paraventricular nuclei of the hypothalamus and released from the posterior pituitary. Hypothalamus contains two types of large neurons to synthesize antidiuretic hormone. About 5/6 of the antidiuretic hormone is synthesized in supraoptic nuclei, and about 1/6 in the paraventricular nuclei of the hypothalamus. So mostly antidiuretic hormone is synthesized in supraoptic nuclei, we can say. Both nuclei have axonal extensions to the posterior pituitary. Once antidiuretic hormone is synthesized, it is transported down the axons or the neurons that terminate in the posterior pituitary. So in this figure, you see this is the brain and hypophysis, and this part is hypothalamus and hypophysis here, and posterior and anterior lobes of hypophysis. There are osmoreceptors in the anterior portions of hypothalamus, and then they are sensitive to changes in the osmolarity of the blood or extracellular fluid, and the osmolarity is high, and mostly supraoptic neurons will synthesize antidiuretic hormone, and then antidiuretic hormone will be released into the blood from the posterior lobe of hypophysis, and then antidiuretic hormone will increase water permeability in the distal tubules and collecting ducts, so that water will be absorbed, and then blood will be diluted. Okay, now osmoreceptors will no longer be stimulated. Okay, and concentrated urine will be formed in this way in the presence of antidiuretic hormone. Of course, medullary hyperosmolarity is required when medulla is not hypertonic. Antidiuretic hormone does not work at that time because concentration gradient is required for water movement. This part will be hyperosmolar, and then antidiuretic hormone will make the wall of collecting ducts and distal tubules permeable to water, so that water will flow from low concentration area to the high concentration area. Okay. All right. Secretion of antidiuretic hormone in response to an osmotic stimulus is rapid. So plasma antidiuretic hormone levels can increase several fold within minutes, providing a rapid means of altering renal excretion of water. Cardiovascular reflex stimulation of antidiuretic hormone release by decreased arterial pressure or decreased blood volume. Antidiuretic hormone release is also controlled by cardiovascular reflexes, including arterial baroreceptor reflex and cardiopulmonary reflex. Afferent stimuli carried by nervus vagus and glossopharyngeus synapse with nuclei of the tractus solitarius, and projections from these nuclei transfer signals to the hypothalamic nuclei that control antidiuretic hormone synthesis and secretion. Whenever blood pressure and blood volume are reduced, such as occurs during hemorrhage, increased antidiuretic hormone secretion is helping to restore blood pressure and blood volume toward normal values. We have seen this in Netler's picture, if you remember. Although the usual day-to-day regulation of antidiuretic hormone secretion is affected mainly by changes in plasma osmolarity, large changes in blood volume, such as occur during hemorrhage, also elicit marked increases in antidiuretic hormone levels. So, in this figure, you see the effect of volume and osmolarity on plasma antidiuretic hormone secretion. This figure shows us that both volume increase and isovolumic volume depletion, volume decrease, okay, and osmotic pressure increase will increase the antidiuretic hormone, okay. Which one is more effective on antidiuretic hormone secretion? If you look at these figures, I think it is obvious that plasma antidiuretic hormone is more responsive to changes in osmolarity, to the concentration of sodium in the blood more, okay? So this is obvious. On the other hand, volume decrease does not increase the antidiuretic hormone that much in the beginning, but if the decrease of volume goes up, and then antidiuretic hormone level starts to increase more steeply, okay? Other stimuli that cause antidiuretic hormone secretion. Various factors can increase or decrease antidiuretic hormone secretion are summarized in figure in table 29.2 will be 29. I'm sorry. Here it is 29 to table 29 to control of antidiuretic hormone secretion. Antidiuretic hormone secretion will be increased in plasma hyperosmolarity when blood volume and blood pressure goes down, nausea, hypoxia, and under the influence of drugs such as morphine, nicotine, and cyclophosphamide. They all increase antidiuretic hormone, so urine formation will be decreased, urine will be concentrated in these conditions. On the other hand, now conditions decreasing the antidiuretic hormone secretion are decreased plasma osmolarity, increased blood volume and blood pressure. In this case, antidiuretic hormone secretion will go down. The drugs, alcohol, clonidine and haloperidol, they all will decrease antidiuretic hormone so that these persons will urinate much and less concentrated, but quite much urine will be formed in decreased antidiuretic hormone conditions. Importance of thirst in controlling extracellular fluid osmolarity and sodium concentration. Kidneys minimize fluid loss through the liver osmoreceptor antidiuretic feedback system. However, adequate fluid intake is necessary to counterbalance fluid losses that normally occur through sweating and breathing and through the intestinal tract. Okay, fluid intake is regulated by thirst mechanism, which together with osmoreceptor antidiuretic hormone mechanism maintains precise control of extracellular fluid osmolarity and sodium concentration. So there is continuous intake of fluids to the body and there is continuous losses of fluid by sweating, breathing, or by feces. So there should be a balance between these two. Many of the stimuli involved in controlling antidiuretic hormone secretion also increase thirst, the conscious desire for water. You would like to drink water. Two of the most important stimuli for thirst are increased extracellular fluid osmolarity and decreased extracellular fluid volume and arterial pressure. A third important stimulus for thirst is angiotensin II, because angiotensin II is also stimulated by low blood volume and low blood pressure. We see these conditions by hemorrhage, okay, in shock table. So the effect of angiotensin II on thirst as well as its actions on the kidneys to decrease fluid excretion help restore blood volume and blood pressure back to normal values. Now in this table you see the conditions increasing thirst feeling. So you would like to drink more water. Increased plasma osmolarity. When you drink water, it will be diluted. When blood volume goes down, blood pressure goes down. So when you drink water, your blood volume goes up and blood pressure goes up. Angiotensin II level is high, and when your mouth is dry. When your mouth is dry, then you feel more thirsty. Okay. Now the other conditions, decreasing the thirst feeling, decreased plasma osmolarity, increased blood volume, and increased blood pressure. In this case, your blood volume, extracellular volume is high and diluted, so you don't need to drink water. Angiotensin II level goes down, and then your stomach is distended. You are full, okay? You don't need to drink water, etc. Other factors that influence water intake include dryness of the mouth and mucous membranes of the esophagus and the degree of gastric distension. These stimuli to the gastrointestinal tract are relatively short-lived, and the desire to drink is completely satisfied only when plasma osmolarity, blood volume, or both return to normal. Antidiuretic hormone and thirst mechanisms operate together to control extracellular osmolarity. Normally, antidiuretic hormone and thirst mechanisms work in parallel to regulate extracellular fluid osmolarity and sodium concentration precisely, despite the constant challenge of dehydration. Even with additional challenges such as high salt intake, these feedback mechanisms are able to keep plasma osmolarity reasonably constant level. When either antidiuretic hormone or thirst mechanisms fails, however, the other ordinarily can still keep extracellular osmolarity and sodium concentration relatively constant. So if one of them does not work, the other one can keep sodium concentration relatively constant. So long as there is sufficient fluid intake to balance the daily obligatory urine volume and water losses caused by respiration, sweating, and gastrointestinal losses. So here, obligatory urine volume, what does it mean? I would like to give you a few information about it. Normally, in our body, there are acids not, how to say, we cannot get rid of them by respiration, not in the case form, okay? And we have to get rid of those acidic substances and also toxic substances from our body by our kidney only. And uh, their amount is about 600 milliosmol. So to get rid of 600 osmolar load, how much urine volume is needed? The highest concentration that our urine can reach is 1200 milliosmol per liter, okay? So how much volume of urine can have 600 osmolar load with a concentration of 1200 milliosmol per liter? Half a liter. Half a liter of 1200 milliosmol per liter concentrated urine contains 600 milliosmol osmolar load. So we have to get rid of 600 milliosmolar toxic substances from our body by kidney, and we need at least half a liter of urine formation in a day. So this obligatory urine volume is very important in patients in intensive care units, okay? We have to follow the patient's urine amount every day, and at least it should be at least half a liter. If it's lower than half a liter in a day, then it should warn us that the patient is going to develop a renal insufficiency, and then toxic substances can be increased in his or her body. So hemodialysis or peritoneal dialysis should be applied to this patient to get rid of these toxic substances. Additionally, insensible water loss occurs in the body by sweating, by respiration, by feces, gastrointestinal losses, okay? So these will be added to the fluid that the patient requires every day. So if both antidiuretic hormone and thirst mechanisms fail simultaneously, however, neither sodium concentration nor osmolarity can be adequately controlled in the blood, in the extracellular fluid. In the absence of these mechanisms, there are no other feedback mechanisms in the body which are able to precisely regulate plasma osmolarity. If you increase the sodium intake, if your antidiuretic hormone system and then thirst system is properly, your blood sodium concentration does not change much, okay? When you take sodium intake, antidiuretic hormone secretion will be increased, more water will be absorbed, so sodium will be diluted, blood concentration, osmolarity will not increase much. If this system is blocked, then sodium will immediately increase the concentration of sodium solute or osmolarity of the extracellular quickly, and then water is not going to be absorbed, and the person is not going to drink water. If these systems work, then the antidiuretic will be increased, water will be absorbed from the kidney, concentrated urine will be formed, and then the person will feel thirsty and will drink more water, and altogether this will dilute the extracellular fluid, so that decrease the concentration of the sodium. Okay. Now, finally, angiotensin II and aldosterone do not normally play a major role in controlling extracellular osmolarity and sodium concentration. It is a little bit surprising here to understand or to know this, to learn this. Angiotensin II and aldosterone are the two most important hormonal regulators of renal tubular sodium reabsorption. Despite the importance of these hormones in regulating sodium excretion, and you increase the sodium intake, plasma sodium concept does not change much. Okay, this is normal. Aldosterone system is working, and this is abnormal when aldosterone in angiotensin system is low. Does not increase or decrease. Now we can go back. So why is that? First, angiotensin II and aldosterone increase both sodium and water reabsorption by the renal tubules, leading to greater extracellular fluid volume and sodium quantity, but little change in sodium concentration. And the second, so long as the antidiuretic hormone and thirst mechanisms are functional, any tendency to sodium tends to dilute the extracellular fluid back toward normal values. Under the extreme conditions associated with complete loss of aldosterone secretion resulting from adrenalectomy or Addison's disease, there is a tremendous loss of sodium by the kidneys, which can lead to decreased plasma sodium concentration. One of the reasons is that large losses of sodium are accompanied by severe volume depression and decreased blood pressure, which can activate the thirst mechanism and lead to further dilution of plasma sodium concentration, even though increased water intake helps minimize decreased body fluid volumes. So, we see in this figure that aldosterone system is not essential in the control of osmolarity, plasma osmolarity, or extracellular fluid osmolarity. Significantly, even with a functional antidiuretic hormone and thirst mechanism. Even so, the antidiuretic hormone and thirst mechanisms is by far the most powerful feedback system in our body to control extracellular fluid. And I think that's all. So today we have learned about urine dilution to produce diluted urine and to produce also concentrated urine. The role of antidiuretic is, and then hyperosmolarity of the medulla in this, and then how to produce hyperosmolar interstitium is very important. I think countercurrent multiplier system is very important, and then for that system to work, we need pumps in thick segment of Henle loop, ascending loop of Henle, both thin and thick segments of ascending loop of Henle is not able to water, is not permeable to water. It's very important. So in this way, by this countercurrent multiplier system, we will produce hyperosmolar medulla. In addition to this countercurrent multiplier system, urea cycle is important. Urea amount in the medulla is high, so that it contributes medullary hyperosmolarity. And vasa recta does not take part in the formation of hyperosmolarity in the medulla. However, it does not disturb this hyperosmotic medulla. Its blood flow amount is very low, and it flows very slowly, okay? So that it doesn't take away the solutes forming hypertonicity of the medulla. In cases of vasodilation in the medulla, for example, when we use aspirin in high amount, then it can cause washout by causing vasodilation of vasa recta or medullary capillaries. This can take away the solutes from the medulla, so that our kidneys can lose their ability to concentrate urine. To form concentrated urine, we need antidiuretic hormone, and antidiuretic hormone is secreted from the posterior hypophysis. Actually, antidiuretic hormone is made in hypothalamus, in supraoptic nuclei of hypothalamus, and it is released to the blood from posterior hypophysis. Okay, when blood osmolarity increases or blood volume goes down, antidiuretic hormone will be released. It will increase the water permeability of collecting ducts and distal tubules of the nephron, and then it will open water channels, and then water will be absorbed from the tubules, distal tubules and collecting ducts, and then urine will be concentrated. If just in opposite case, when our blood is diluted, if you drink so much water, for example, and your blood osmolarity is low, your blood volume is high, and then in this case antidiuretic hormone secretion will be inhibited, and then in the tubule, distal tubules and collecting ducts, water will not be absorbed in the absence of antidiuretic hormone. So much more diluted, 50 milliosmol diluted urine will be formed in this case. Renin-angiotensin system, aldosterone, antidiuretic hormone, feeling thirsty, they all play a role in the regulation of blood flow and also blood osmolarity. Antidiuretic hormone and feeling thirsty are very important mechanisms in regulation of blood osmolarity. On the other hand, aldosterone is not that important. Angiotensin 2 and aldosterone are not that important in the regulation of plasma sodium concentration. Okay, because they increases both sodium and volume or water at the same time, so the concentration of sodium is not affected much. Okay, I think that's all. If you have any questions, I can answer your questions. Do you have any questions? Any questions?
Yok hocam, sağ olun.
Tamam Abdullah. Evet, teşekkür ediyorum o zaman. Thank you very much for attending this lecture.
Sağ olun.